have you. What we're going to do today is first we're going to do an hour, just kind of high-level overview of dialectical behavior therapy, how it is structured based on the research right now. I'll talk a little about adaptations as we go through, but basically this is an overview of DBT as it's written. We're going to start with a little teeny bit of mindfulness, and we debate about whether or not to put this on today's training. And in DBT, consultation team begins with mindfulness, and skills training begins with mindfulness, and it was just very hard for us to let go of the idea of starting with mindfulness. So there's a lot to be said about mindfulness, and the core mindfulness skills are the backbone skills of DBT, and they really are about helping clients get to a place where they're involved in their lives, kind of completely in their lives in a moment, not attached to past suffering or worrying about the future, but about really experiencing every moment as it comes and knowing their own experiences, so know their own emotions and thoughts. And a lot of what we do in DBT is practicing different ways to do mindfulness. So different skills mindfulness that we have in the skill training group, we have different practices. There's a lot about posture and how we're going to do this, but what I would like for you to do just for the sake of expedience today is sit straight in your chair with your feet on the ground. Keep your eyes open when we do this. Take hands and put them in your lap in an open position. So don't close your fist or close your hands. Just rest them comfortably in your lap. And then have a posture that's not slumping, that's not totally erect, one that's comfortable. If we're doing a 20-minute mindfulness, you could hold for 20 minutes. But we're just going to do a minute or two. And what we're going to do is take 5 breaths. You don't change your breath when you do it. This is about noticing your breathing. So all you need to do is to breathe in, and as you breathe in, count 1, and you're breathing out, count 2. As you're breathing in, count 3, and count to 10, so that you have done 10 breaths. If you pause, start again, although you won't have a whole lot of time to start over. You get judgmental of yourself. All of your judgments go back. So you're just noticing your breath as it comes in and goes out, and counting 1, 2, 3, 4. So I have this bell here. Kind of see it if I hold it up. I ring it 3 times to start us and once to finish it. You'll see me leaning over. That's because I have a microphone that's attached to my head, and I realized earlier that you can hear it unless I hold it closer. Okay, so we're just going to start. I'm going to talk briefly about how DBT came to be, and then just tell you a little bit about the structure, the framework, and the parts of dialectical behavior therapy. So this first slide is really about the research studies that have been done in DBT. There are actually 10 now studies that have been done. One hasn't quite been published yet, that are randomized trials on DBT, This one was in 1991, and that was the University of Washington, and it was DBT versus treatment as usual. So what people were already getting in the community, kind of standard mental health treatment. And it found that suicide attempts, inpatient hospitalization, emergency room visits, harm behaviors, all came down in a year of treatment. So this one, and most of the other ones, were for the standard year of treatment. Then Coons in 2001 replicated that study, but on the 6-month treatment in the VA in Durham, North Carolina, which was important because it was the first time somebody had done a study out of the University of Washington and showed that basically other people other than Marsha Linehan could do the treatment. Couch and Safer have done some studies on DBT with eating disorders, primarily with binge eating disorder and with bulimia. And so we have studies by them that show that it's effective, especially with binge eating, in bringing down the disorder. DBT has also had some randomized trials with substance abuse, like opiate-dependent with borderline personality disorder who were suicidal. So they were a group. And then Tom Lynch did DBT with the elderly depressed. He's right now doing a study that is DBT with over-controlled people, thinking that borderline personality disorder, there are people who kind of under-control their emotions. The emotions are big and out of control, and their behaviors are out of control. There's a group of personality disorders that are the exact opposite, that over-control everything. The other thing is with adolescents, there are a couple of studies going on now, kind of late adolescent transition stage that has just finished in New Zealand, the big study. And there's a larger scale study in Norway on DBT with suicidal adolescents. And the one that's just kicking off at the University of Washington and UCLA that is DBT with adolescents. It's a 6-month program as opposed to a year-long program. So dialectics, what DBT? Well, you kind of have to understand the history of DBT. So, DBT was being developed in the early 80s, and Linehan, who developed the treatment, didn't really want to work with people with borderline personality disorder. It's not that she didn't want to work with them, really. It was that she didn't know who they were. And she was not a person who focused on diagnosis. She was a person who wanted to treat suicidal behaviors. And she started trying to treat suicidal behaviors. She had this whole group of people that it just didn't work with. And part of the problem was because they had so many behaviors. They would come in and they would be drinking and drugging and binging and purging and suicidal and self-harming. Every time she tried to treat one thing with a treatment that she knew that worked, it lapsed because something else would pop up. It didn't really have a structure that allowed her to pick a behavior, change it on another behavior, and kind of know how to prioritize the session. At treatments over time, there was basically the acceptance-based treatments. Those were the client-centered therapies. The very, very low dropouts. People stay in those treatments for a long time. But the research hasn't shown that you get a lot of behavioral change. So the people stay around, which is really great. They don't really change their behavior. Then we have the cognitive behavioral therapies that are really change-oriented. They push people to change their behavior, and they teach them new stuff. And they're really, about you want to have the same behaviors that have been making you miserable, except that, especially in those early 80s, there's no emphasis on relationship and on acceptance. And with the out-of-control, really sensitive people, they dropped out of therapy. And if you look at the data on personality disorder especially, the dropout rate was usually like 70 or 80%. So people weren't keeping people with BPD in treatment. I just started trying to bring these two ideas together, the acceptance, like where the client is, and acknowledging her current distress and the reasons for it, and at the same time teaching her how to change behavior. And it really helps because people sensitive aren't stated problems. solvers. When you go in and trying to help them solve their problems, they feel invalidated by you. You're saying it's all their fault. And we have some deal with that in DBT. The fact is, if I'm always saying to the client, what are you going to do about your mom? How are you going to change your mom? Then in ways I'm telling her that the onus of that is on her, of that change. That really dysregulates these very sensitive people. So bringing these things together with what we call dialectics. Dialectics balances out acceptance, so the client-centered therapies, and change, the more kind of behavioral therapies. And instead, you don't have 50% and 50%. There are times when you're really strong on change. You're really pushing. The client is working, and you've got something to figure out. And sometimes when you back off and you're more about acceptance, and dialectics is how do you get that balance? So, is a second. One, it's a way of getting balance. So, what I say to clients is, if you're in a place that's extreme, miserable, and what I usually use are, if you're too cold, then you're miserable. I'm always miserable if I'm cold. Too hot, most people are miserable. And most people, because I love hot. You have too much to do, you're miserable. Many of us in the mental health field know exactly what that feels like. If you have enough to do, though, you're miserable too. And dialectics says, bring your life into a balanced place. Most of us who have too much to do, we aspire to balance. So what we're saying to our clients is, keep balance in there too, so that your thoughts and your emotions and the behaviors that accompany them will be of more what we call middle path. The other dialectic is it's synthesizing two positions. So what happens with people sometimes in therapy is they get polarized, or on an inpatient unit, or in a partial hospitalization where you're the saying, do this, do this, do this. The client is saying, I'm not, and here's why. And people start having a tug of war, and everybody is kind of attached to their position. And dialectics says, there's probably truth in both positions. There's the wisdom that the clinical team has and they want the client to do. And there's the client's own ability and autonomy to say that doesn't work for me. And how do you bring those two to a new place? And when you do, then it becomes another set of opposites. So part of dialectics is synthesizing opposing positions. And this part is looking for what we're leaving out. The reality is we get going on a direction and we have our perception of what we see. We think to be truth in a situation and believe that stuff all the time because we're heading down this path. I do this a lot when I'm teaching where, I think I know where I'm going and I head off in one direction and I realize later that I left out like 15 things that I wanted to say or would have been effective to say. And what DBT says is let's ask ourselves constantly, what are we leaving out here? Teams ask us, what am I not seeing? Your DBT therapists all the time, they talk like this, like, what am I not do? What am I not seeing? What am I leaving out? Where we're acknowledging they don't always see the whole and that other people can help us with that. And so we do what we call dialectical assessment, which is looking for the piece that we're leaving out. So all that role in the treatment. Well, that's what we're going to talk about for the next period of time. For who is DBT effective? So we talked about the research. So we know some diagnostic populations. We know borderline personality disorder. We know treatment-resistant depression. We're now knowing more and more about different eating disorder and about adolescents with emotional control problems and behavioral control problems. But what if you're a unit or system and can't take people by diagnosis, or an inpatient unit, and you have a whole group of people that come to you? Who are you looking for whom DBT might help? Well, here are 5 basic ways of looking at it. These are 5 problems that we can treat in DBT. If you look at them purely, they are a reconfiguration of the diagnostic criteria in the DSM-4 for borderline personality disorder. So all those 9 little pieces that make up BPD in the DSM are in these 5 areas. But Marsha, I think very wisely when she started writing DBT, think that they looked treatable. You know, they things like frantic efforts to avoid abandonment, all kind of in disarray. And, you know, I can see if someone gave that diagnosis and I looked that up in the book or Googled it, I would feel very hopeless when I saw it. And so these have been reformulated into 5 areas that are treatable. These are things that we actually target in DBT. And when we target these areas, bring that diagnosis down. So first, emotion dysregulation. And this is a primary problem in the people we treat in DBT. It is our emotionally very sensitive, and they have trouble regulating emotion. So they usually have kind of out of control anger, and that's on the diagnostic criteria, but often I see sadness and shame as being more problematic than anger. Anger is kind of the emotion that they experience after they experience sadness, shame. But also guilt, fear, anxiety, there's emotion, and then and no ability to really control that emotion. Often they don't know what they're feeling until later, what their emotions are, and they come up, they're just kind of overwhelmed by them, and then they can't do anything, and so they just kind of go with them and engage in whatever the behavior tells them to do, which can sometimes have catastrophic consequences. Record, I think as you see people get older, they often get punished for having emotional displays, and get populations, especially when you get people who are middle aged, where they actually have the opposite extreme. They have like emotional over control. So he will say to you, I don't do sadness, I do anger, I have those emotions. And you watch them if you have periods where it all kinds of bubbles up and kind of rolls out of them. And, you know, a lot of times what they're having is kind of a suppression effect, where they suppress emotion, and then it kind of blows up on them in the moment. So that is the first, emotion dysregulation. The second, dysregulation. This is the reason that many people with BPD and other behavioral dysregulations come into treatment, because they get suicidal. They get harming, they cut, they burn, they pull their hair out, they binge, they purge, drink, drug, gamble, shoplift. They have all of what other people call impulsive behaviors or too many behaviors, like they overspend me. And so we often assess things with this. To be clear, DBT does not require that a person has suicidal self-harm behavior, and DBT does not either. So people sometimes will come into treatment with us who are not actively suicidal, they're not actively cutting, and that's okay, because often they have problems in all these other areas. Emotional dysregulation is about regulating relationships. You know, it's a lot of skills to have relationships. And you can see that if you were a person who had out-of-control emotions, it would be really hard to have out-of-control emotions and in-control relationships. They go together. If your emotions get out of control, you might end relationships prematurely or force relationships that are not wise relationships. And so our people who come into treatment often have a really hard time with relationships. They're afraid that they're going to end, that they behave in ways that actually end the behavior. So this is where behavioral dysregulation kind of meets in its personal dysregulation. They require a lot of reassurance sometimes. They're relationship phobic, so they just say, I'm not going to have any relationship except they're miserable because they don't. They can't ask for what they want, get what they need in relationships. The fourth is cognitive dysregulation. So in a lot of people, this is attentional control. Many of our people have problems with ADHD or just basically being able to concentrate, even if it's special for diagnosis. So on controlling attention with mindfulness, basically, and I will get to that a little bit, but They also can appear to be a little paranoid, and it's not the diagnostic paranoia, but it's often cued up something that's happening in the environment, stressors that are happening in their lives, or they're not sleeping. Something going on that kind of sets them up for paranoia. I had a client this morning who's got a lot of work stress, and one of his types of bushes in his yard is dying. And he said, I look out there and they're all brown, think, oh, well, maybe someone's poisoning my bushes. He said, then my wise mind kicks in, which is to know kind of what is wise. And he said, I realize that's not true, but for a moment I absolutely believe it. And it's really related to the stress in his life. You can see this can happen, where people can't really talk themselves out of it as quickly as he can, where people actually get a little psychotic in certain environmental contexts. And this is dissociation and cognitive dysregulation. Many of our people, depending on the research you read, but they dissociate. And so we do a really good dissociation assessment to see if they're losing time or if they're coming out, kind of have to use their language to see what's going on. Finally, I think really one of the more complex problems that our people have is self-dysregulation. This is not a self-esteem problem. This is a not knowing who you are problem. I often tell clients and say, it's that I have poor self-esteem, but actually that would be stress. They know who they are, and they don't know what their values are. They don't know what they like or dislike often. You can see them in a room full of people when decisions are being made, that they're kind of scanning the environment and looking for what other people are doing. And then they say, yeah, I'm going to do that, which is problematic, especially when they're young. They kind of fight in with crowds that can bring things that are not helpful. I don't even know that their values are saying not to do it necessarily. So those are the people we look for DBT. Like I said, you don't have to have all of these, but you will have some severe pattern of these behaviors. And if they have borderline personality disorder as a diagnosis, you will see most of these. So they agree to come into DBT. Well, big agreement is that they have to stop suicide and self-harm behavior. They have to agree to do that. Sometimes to a client, you have to agree to stop, and they say, okay, fine. Some more as if they agree to work on suicidal behaviors. But your goal is to bring suicidal behavior down, to get it to stop. And if they say, no, suicide is a lifestyle for me, cutting is a lifestyle for me, or I can't make that agreement, you don't move on with the treatment until you get that agreement. And you can put some work into that. That is a necessary agreement to enter into DBT. You still have to agree to attend to the relationship with your therapist. This is a pretty intense therapy. Although we don't meet every day, there's a lot of work that can be done. And to address the dropout issue for these people, one of the things that we ask is for them to agree to deal with relationship problems with us. They have to agree to come to session, and they have to agree to whatever it is the system might agree to. So research protocols, payments, psychiatric care, whatever it is that the system asks for. In return, DBT therapists agree to do DBT, which actually is a lot harder to do sound. But what we say is, I will do DBT, and I'll get consultation, and I will attend a team that will help keep my feet to the flame here and make sure I'm doing DBT, and I'll get supervision when I need it, and of course adhere to all the legal, ethical guidelines that are around, and to practice within our scope of practice, which are standard psychotherapy agreements. It has 4 stages. If you read the research, most of the research is stage 1 DBT. From the system, brings people in treatment if they're in stage 1. And some people, if you have a short-term unit or acute unit that's 6 months or less, you may only have the people when they're in stage 1. Stage 2, there is a study being done right now, a really great study that we're looking forward to on stage 2 in DBT. And then stage 3 and stage 4, I'll talk about in a second. So what is stage 1? Stage 1 is when a client's behaviors are out of control. Really all it is. They have to have multiple out of control problems in multiple areas. So when back on that list, they'll have problems in a lot of those areas. And what we're trying to get to happen there is we're just trying to get their behavior under control. It's to deal with the other problems in someone's life. They're getting arrested, or being hospitalized, or dropping out. So work on those behaviors first. Sometimes in standard DBT, that's usually around a year of treatment. And sometimes people finish that and they're finished with that. But a lot of times you get their behavior under control and basically they're still miserable. There's a lot of pain because they aren't experiencing emotion, or they have trauma issues from the past or things that they have avoided. So DBT is largely a prolonged exposure treatment to help people experience emotions and situations that they may be avoiding. And sometimes you have a client who's like, I've been in therapy for 25 years dealing with my childhood trauma. I don't need it anymore. So you don't have to do it. But a lot of people, when they come into therapy, part of what brings them into therapy is some kind of trauma that they had when they were younger. That really is an important piece of the treatment for them. We do that in stage 2, when behavior is under control. And the way I explain this to my clients is that, when we do trauma work is grueling. It's painful. It's kind of its own crisis. When your level of functioning is really great, you've got meaningful relationships and you can regulate emotions and behaviors pretty well, it's still its own kind of crisis. If you have other crises going on in your life already, then do trauma work on top of that really can set you up for what one client calls crash. Crash can be, in many cases, more suicide attempts, higher levels of self-harm. So stage 2 is to work or exposure work or work on anything that's about experiencing those emotions. So basically now you have behavior down and emotion being experienced and misery coming down. So you have a client who just has kind of ordinary, I call it pit-stop therapy. They come in for marriage therapy or vocational therapy, or they have, some depression firing up, and so they might come into therapy for that. Or they have a panic attack, and that's all they have left. So you kind of have a single diagnosis treatment for which a problem for which there's a treatment. We call that stage 3. Some people do that in DBT. Some people finish at that point. And stage 4 is highly theoretical. I would love to say that we've written this, but we've tried to write it for a million years, and we just haven't gotten it done yet. But it is basically, people, they get everything under control. Their lives are moving along, but they just need a greater depth of experience in their lives. And so stage 4 is whatever that might be. It might be going to psychoanalysis. It might be, going on spiritual retreats or finding a spiritual path, but helping point people in that direction. Usually when I'm pointing someone in that direction, they're finished with me, and I'm like, here's the next step, and then them on their way. So one, I said the one that most of us see, and if you're in acute unit, then this will definitely be more of what you see. And it has specific behavioral targets. And if you remember in the beginning, I said that one of the things that Marcia realized was that there were so many problems that were percolating around. It's difficult to choose which problem to work on and to know in a session when a client came in just with all these things going on, how to prioritize it. One of the structural pieces of DBT is that we go ahead and prioritize that. We use a treatment hierarchy in our brains at all time. And when the client comes in, a lot of problems in a week, this is how we put behaviors into what we're going to do in a session and what we do overall in the treatment program. This is not what skills trainers do. Skills trainers have a whole different set of targets. Skill coaches have a different set of targets because most people don't actually work on the life-threatening behavior. They coach the client until they can get to the person who works on the life-threatening behavior. So the all goal with DBT, to get over with it. It's about suicidal behavior. Suicidal behavior is fundamentally my life is not worth living. I know people who have meaningful activity, relationship, things that make them feel valuable, and then say, and I want to die, and I want to kill myself. Usually the people who don't have those things, who want to kill themselves. So the first thing we ask our clients to do is to come up with a life worth living goal. And a therapy goal, as you think about conditional therapy goals, it really is, what is it that makes your life better, that you think would make your life better? A lot of times for adults and for your stage adolescents, it's coming up with some kind of career or vocational goal. But sometimes it's a relationship goal. Sometimes it starts out just, I want to be happy, and then you've got to work on what is happy and what makes you happy. Sometimes you start on one goal, and then the client realizes that wasn't their goal at all, and they're going to switch goals, which is okay. But they can be anything. I had a client one time, I've actually had several clients, whose goal was to get married. That's what she did in life. She figured she would not be suicidal if she got married. I have one right now. Her whole goal is to have friends. She has problems having friends, so I can understand that would be a goal. She can't really make friends or keep friends. But that's the goal. What we're working on. Now we have to get some problems in this. There are some problems. There are some things that are keeping her from having friends. She texts or calls people constantly if she's their best friend. Gets distressed if there's the person talks to anybody else. These are all things that we put on that list of problems that are keeping them from the life worth living. The first living goal is to have friends. So you take that and then you map these targets on it, which is this. Number one thing, the number one priority in any session, decreasing life-threatening behaviors. So self-harm, homicide in some cases, or assaultive behaviors. You have to work on bringing those down. So if a client comes into session and they've engaged in any of those behaviors for a week, or if their ideation is spiking, they have a baseline of 4 out of 0 to 5 scale. Like they're pretty suicidal all the time. But it spikes up to a 5 one day. Or, my clients on a 0 to 5 scale will get a 10, which I figure is pretty catastrophic since my scale stopped at 5. Then you make sure that the priority of the session goes to that behavior. As a client, it's hard to get friends if you're deaf. As far as I know, doggone near impossible. Priority has to be to keep you alive. And, I told the friend girl, it's not, people don't want to be friends with suicidal people. I have to hear that, by the way. She seriously thought that people would want to be friends with her more if she was suicidal because they feel sorry for her. And I think that they would feel sorry for her, they wouldn't be hanging out. And most of us don't have that as criteria for friends. So that's how she agreed to work on not being so suicidal. The next thing is what we call therapy interfering behavior. We want to decrease therapy interfering behaviors. Therapy interfering behaviors are anything that affects our clients or the therapist's motivation to be in therapy. So clients coming late, not doing their homework, being marginally disruptive on a unit, being inordinate staff, all of that can be therapy interfering. So come late, taking phone calls, leaving for code, not attending, kind of daydreaming while the client's talking. Those are therapy interfering behaviors on the part of the therapist. And any one of those could cause the therapy to collapse. So we say, the only thing that's more important than the therapeutic relationship is the client life. Clients start with me, I ask them, Is there anything that we need to talk about with the relationship? I'll look and, observe myself and say, nope, nothing here. How about you? But I try to get them so that they actually can talk about what their experience of the therapeutic relationship is. If they drop out of therapy, I'm not going to be helping. The next is quality of life interfering. So if you don't have a side or self-harm behavior that week, already addressed it, you don't have therapy interfering behavior or addressed it, then you get into quality of life interfering behavior. And I write a list of quality of life interfering behaviors for all my clients because by definition they have multiple quality of life interfering behaviors. And then I put them in a little hierarchy too because they can have 5, 6, 8, 10 of these. So the substance abuse, eating disorder behavior, gambling, shoplifting, have problems with work, having problems in a relationship, all those would go on as well. Clients come in and we're getting this little agenda with the targets. We just say, what do you want to be working on? All of the behaviors should decrease. They're behaviors we want to go down. So you can't make a behavior go down if you don't put something new in its place. It just won't go off into a vacuum. So as people learn new behaviors. And there are the 4 sets of skills that are in our skills training in DBT. So the first mindfulness skills, we've talked a little bit about mindfulness skills, but the skills of how to know your own experience, engage in it fully, not beat up on yourself, listen to your own wisdom. Next is the stress tolerance skills, which are how you get through the moment. Like, stuff happens in life, and we're always telling our clients that being skillful does not mean that you're never going to have distress. Things aren't going to happen. It's a part of life. But often what happens with our clients is something happens. They get from their bank that someone may be stealing their identity, and they can't deal with that because it's the weekend. So that emotion goes up, and they can't tolerate it, and so then they go out and get drunk, and then they, spend money they didn't have, and then feel guilty about spending that money, so then they end up with a suicide attempt or self-harming. And so we're saying, here's what you do when life interferes to keep things from getting worse. So you don't engage in out-of-control behaviors. How do you refocus your attention? How do you do other things? Keep yourself from engaging in impulsive behaviors. How do you slow your response down? So even if you decide to go out with your friends, you're not going out with your friends and getting drunk. In kind of personal skills, pretty self-explanatory, but it's really how you ask somebody for something, say no, get your opinion taken seriously, and simultaneously keep that relationship balanced out, and simultaneously feel about yourself. What I notice about our people is they often get people to do what they want. You will suicidal behaviors, or they'll get very dysregulated and distraught. They'll yell or they'll plead, and people will give them something, but they'll not like them afterwards. So lose the relationship, but they got what they wanted. Or they might get what they want. Person still like them. But what happened because they tried to get it, and they're badly about themselves. So interpersonal effectiveness, how do you juggle all 3 of those things at once? So everybody kind of comes out on the side of key relationships and keeping yourself. So there's emotion regulation. These are pretty complicated skills, but very, very necessary. And how do you know an emotion? A lot of our clients say sad, mad, glad, and bad. They don't really even know what those emotions are. So being able to look inside yourself and say, okay, my heart's beating fast, my blood is rushing, my stomach is clenched up, I have an urge to, go to my bedroom and shut the door and avoid all of this. Oh, this is fear. I'm fear. And research shows that the minute you can name an emotion, it automatically starts regulating. It's becoming more manageable. So what we do in emotion regulation is teach people what emotion they're having. But when you know it, then decide what do you want to do with it. Do you keep it around and use it for what its function is? Do you want to change it? How do you increase positive emotions in your life so that you balance out negative emotions, so that you have memories of more positive times, so that you can use those when you're distressed to experience a negative emotion when it's optional to experience it. You know, something sad happens in your life. If someone who you love dies, then experiencing sadness and grief is what you've got to do to get to the other side of it. And sometimes people don't do that. It's because they're so afraid of emotion. So how do you let yourself have that emotion? That's really difficult. These are all things that we teach in our skills training group. These are new behaviors to replace their old behaviors. So do all that. So this is what comprehensive DBT looks like. A lot of people say, well, we're just doing skills training. That's great. I mean, I wouldn't tell anyone not to do skills training because I think I have to do little skills. It helps me to be able to have names to put on skills when I'm distressed. But skill training group alone is not DBT. What you have to be DBT is you have to meet 5 functions. These are functions of DBT, and I will tell you what some of the ways that are that people meet those functions. So the first is to enhance capabilities. A lot of times when a person is engaging in an out-of-control behavior, so let's say they're cutting, other people get really judgmental and say, she just wants to do that. She wants to feel better. She's just getting attention for that. A lot of times it is that what she knows how to do in that moment when she's herself is cut herself. That's all she knows, right? She has other skills. So you have a way to say, no, these are other things to do. Those 4 areas I just talked about, those are skills. They enhance the capabilities. To enhance capabilities might be a psychoeducational group where you teach people about how families function or medications that helps people be able to use skills that they're learning. The function is improving motivation. With most of us, when we're trying to change a behavior, is we have behavior, we know. Like literally, you're trying to get yourself to exercise. Well, you actually know how to use the Bowflex, the Nordic track. You may actually have it. It may be in your basement. And you know how to turn it on, and you know how to put your tennis shoes on, and you know how to stand on that treadmill, and you actually know how to walk, right? So you have all of the capabilities. What you don't have is the motivation. So every weekend, you spend all weekend thinking about and telling people how you'll start getting on the Nordic track on Monday morning, and Monday morning comes on the Nordic track. That is you're having a motivational problem. And what we have to do in DBT is figure out what that is. Sometimes it's that emotions interfere. So you're not on the Nordic track because you have anxiety about not getting in shape. Or it could be that you have thoughts that interfere. If you want to work, I'll never keep it up. Why exercise today? Because I won't tomorrow. I've had these failures for a long time. Or it could be that things are reinforced laying in bed behavior as opposed to getting on the Nordic track behavior. So you're tired and it just feels better to do this. So it's that we have some judgment about motivation. It is that you've got to have a mechanism to look at what is interfering with the person actually engaging in the behaviors that they have. Usually that is done with individual therapy. On residential units and inpatient units and partial programs, a lot of times that new interventions. That's where people are constantly talking to the client, asking the client, now, what caused you to do that? Well, what interfered with your using this skill? Actually, people surrounding them are things with improving motivation. A generalization is really important. All DBT programs have to have some way of making sure that what the client is learning, what the client knows how to do, gets from one context to the other. Human behavior does not generalize. So you can learn something in one context, not be able to do it in another. A prime example of that, if you've ever tried to give up smoking cigarettes or eating chocolate, now you can do it at home. But then you work, next thing you know, slamming a candy bar, right? Someone orders it to you, you eat it, or you looked in a drawer and you found the candy bar that you had hidden away, or you just were having a really bad day. What works at home doesn't necessarily work at work. I have some way of getting the no chocolate at home behavior to get to the opposite. And we do is we put people in place for that help say, oh no, remember, you said you weren't going to eat chocolate. This is what I want you to do. What candy bar? Oh, that breaks my heart to say that, but that's what I'd say. Throw it away. Give it to somebody else. A generalization has to happen, and it happens in different ways. One way is to get people to do homework from skills groups. So actually say, you've got these skills, you've learned them for no chocolate behavior. Let's practice how you engage in no chocolate behavior. So go to work, and I want you to say no one time to chocolate. Here are skills for saying no to chocolate. Come back next week and tell us how saying no to chocolate works. It could be to have coaches that are in the milieu where staff can say, did they just offer you a candy bar? Let me tell you how to say no to that candy bar. Here's what I want you to say. Say it. Fabulous. Wonderful. On outpatient DBT, we use telephone consultation. So they will call and say, I've got the candy bar in my hand. What should we do? And we tell them the skills to use to get rid of the candy bar. Or do they know to the candy bar? Candy, what can I say? That's an easy example, but it seems to work. During the environment, making sure that what we're doing in our area for the treatment and the behavioral change as best it can. And then, in ways that are possible, helping the client to structure their environment, that it supports what we're doing. Because it's very easy, I'm sure you guys have all seen this, where you have a person, they're in treatment, and you have them changing behavior, and then they go home and they try to do what they were doing with you, and somebody at home either reacts negatively to it, or they do what they've always done, and it punishes that behavior inadvertently. I don't have judgments about this happening. It just happens. That's how life and human beings are. So you got to have a way of making sure that that's not going to happen as best you can. So one way we do that is we bring in family members. We do friends and family groups or caregiver groups where they might come to skills training groups. So they learn what we're doing, how we're doing it. They learn to regulate emotion better, and they learn ways to respond to your client or yourself in ways that are more effective. We make sure that our structure supports what we're doing. It's really easy to get away from this. I had someone the other day, I worked with my original DBT programs that for what they really wanted was to have time on Fridays to do paperwork. So they told their clients that they were not available to coach them on Friday afternoons ever. But they call the emergency line. It's a health center. So suppose this happens at Friday afternoon at 4:30 when a client calls an emergency line at a mental health center that closes at 5 o'clock and says, I'm suicidal. The line will say, go to your local emergency room. And people were getting admitted on Friday afternoon during that time. So we realized that that's when everybody was getting admitted. What we had to do was find another solution. Actually, what we all did was we agreed to keep taking phone calls and answer the phone during that time. But we had to make some intervention because it was kind of reversing what we were trying to do through best of intentions by everybody. Structuring the environment is a piece of DBT. You've got to be able to treat the people who are treating these out-of-control clients. So you've got to have some meeting that supports and encourages and does for your therapist and your co-staff what we're doing for our clients. And we call that consultation. Only use of DBT that's absolutely mandatory. Everybody who is doing DBT in a clinical form has to go to a consultation team once a week. I see you for about 6 hours on that right now, but I'm not going to. So basically, when a client comes into standard DBT, they go to group once a week, they go to individual once a week, they get telephone consultation as needed. We structure the environment by giving options with families and psych education and case management as needed, and then everybody goes to consultation. Make sure that everybody knows that DBT still is a cognitive behavior therapy, which means that we do all the pieces and parts of standard DBT in DBT. A big piece of what we do is called the chain analysis, which is a moment-by-moment examination of the behaviors, a problem behavior that a client has with new skills put in. We call that solution analysis. We also do exposure and contingency management, and that's part of the overall structuring of the environment of your clinic, is that you look at what contingencies are at play and how you might modify them. Balanced out with CBT is validation, and I already talked about validation a certain amount at the beginning of this talk, but validation is the primary acceptance strategy in DBT. It is about saying to the client that you're experiencing, thinking, feeling makes sense. I understand. There's truth in this. At times it's really hard to pull out a little bit of truth. You've got all of this kind of dysfunctional and emotional behavior going on, and you'll look for, of course she's experiencing that. Of course she feels like shutting down that emotion. That emotion has scared her when she's had that emotion in the past. It's had catastrophic consequences. So of course she's looking for a way to do that. It doesn't have to be cutting is valid. I don't say to anybody, and never has, well, I can understand why you cut. Totally effective way of changing. But so you don't validate the invalid, but look for something that can validate. And that serves the function of bringing the client's emotion down. So you're kind of like a barometer where you're watching, and the client's emotions start going up, and you validate and bring them on. And then it's when they get down, you kind of change and go up again, and you validate and you bring them down, and then you go back to change. And that's a little bit of the depth of DBT. I put slide in so people could see it. It's more philosophical than I really want to be in this moment, but it's about how dialectics is how you see the world. And we believe that we are connected to our clients and they're connected to us, and we impact and influence each other. And a big piece of that is then that we are beholden to the same behavioral principles that our clients are. So they can engage in behaviors that reinforce and shape our behaviors, or vice versa. And they're all kind of moving along in this kind of connected way. And then we don't exist without everybody else in their family and everybody else on the unit. Putting this all together, I feel like 5 minutes, I think. And putting this all together is the dialectics is the way that you balance out this acceptance and the change. So that you're making sure that your client is moving forward, but you are also validating and encouraging and soothing and acknowledging their experience in the moment. Shows how the treatment lines up between these ideas of acceptance and change and this primary dialectic of acceptance and change. And I'll show you another slide and that shows that, so I will come back to that. I just want to make sure that everybody who sees this video knows consultation team is of utmost importance, because therapy can get ineffective waiting these clients if they don't have some mechanism to keep them from burnout, to keep them getting rigid, and to make sure that they do the treatment. So either just starting with just skills training, maybe you have skills training and consultation teams, because training can be a little dysregulating for the therapist. When we have 8 or 10 or 12 people in there who are highly dysregulated themselves, it can be very difficult. Somebody who does any of the DBT has to be in this consultation team. You have to agree that you'll come every week, that it will be a priority, that coolness if you're on vacation or sick. But you won't be filling out treatment plans or doing other things in the team. Then you'll be discussing each other or issues out of the team, and an agreement that we will all be equally vulnerable. So hierarchy does not enter into the consultation team room. This is a very difficult thing to do if you're in a hierarchical environment. When you have supervisors on teams, and sometimes you have non-clinical staff on team, people who write evaluations for other people on the team, it has everybody leave that piece out. And when you come to team, everybody is equal. I wanted to show you about the central dialectic. So look at this. This is the orchestra of DBT. And, you know, orchestras have all these different instruments and sounds. They have the woodwinds and the brasses and the strings and the percussion and the pianos. And they all are playing their own little parts, and sometimes they're playing really different parts. And then they have the conductor who brings them all together, and the percussion that kind of sets tone. And when it all comes together, it becomes music. It becomes beautiful music, hopefully. That's what DBT is. We have acceptance, which is like one set of the orchestra, with case management strategies and how we communicate this kind of warm, genuine involvement, validation. And the other side, we have the brass section, you know, that's change, that's about how to intervene with the client so that you teach them how to be their own interventionists, and use irreverent communication, which is responding just a little unexpectedly. And then the CBT principles. Then the consultation team, the cushion section that keeps everything kind of moving along at a pace. It sets the rhythm. It keeps everybody going together. And you have dialectics, which is the composer, the person who brings up this section and brings down this section, speeds things up, slows things down, says get louder, get softer. That dialectics, it pulls all of that together so that it becomes music. So if you're watching this, the thing for you to do to figure out who's going to be on your consultation team, decide who you're going to treat, looking at what kind of program you're going to have, and what are going to be the pieces and the parts of the program. Then you've got to actually learn DBT. It's going to take some time, and I recommend getting an expert or a supervisor or a consultant, somebody who can make sure that you're actually doing what you think you're doing. It's very easy to get distracted in DBT and take your whole program in a direction that you don't want to go. That's it. I think we're opening up for questions now. So we're going to turn on that other